All right, Doc. So we are back for Ask the Doc, and it's almost Thanksgiving. So glad to see you right before the holidays. Thanks for making time because I know you're flying back home and everything. So you're
Always
squeezing
my
me
pleasure.
in.
No,
It's nice.
always my pleasure. You know that.
All right, so let's get started right away. Guys, love the show. Thanks for all the advice. My question is, I have a damaged subclavian vein. It has a scarring and old clot in it from multiple injuries and procedures/surgery. Is there a greater risk of clotting from TRT? I want to know before I start if it's safe to start. Do I need to get my blood perk done sooner or more often? Thank you. And I'm going to tie this with a little bit more once you're done answering that because a friend of mine actually wanted to know. So
Go ahead.
Oh, right away? Okay, good. So the second part would be basically I'm 61 years old. 100%, I think he means drug-free steroids, but he's also pro-steroid, which means he doesn't have no issues with it. Swarm-free, etc. I inherited two markers that put me at risk for blood clot already. Already had DVT, and I wanted to try HRT. Would there be any way for me to do this with this history?
Yeah, those two tie in together really well because the question comes up a lot, or actually the statement comes up a lot because someone will come from another doctor who, I think even admittedly by the doctor will not have a background in this or hasn't done the research because the research has been done. But the claim is that, testosterone will cause an increased risk of blood clots. And you hear that often. And I don't know if it's based on, it's really the medical world's version of bro science, if you will, kind of passed along or sort of more of the, well, if then that, so, or like, A plus B equals C, they make a jump directly from A to C, or I guess that's not as good an example of, A plus B equals C and A plus D equals C. So what would that be? D plus, I'm screwing up the analogy here, but in other words, you draw conclusions from data that might seem to make, I'll call it common sense to you, but doesn't work physiologically. How's that? Forget about the analogies. Maybe you can edit that version out. But my point is that the evidence shows, and if you speak to a hematologist whose expertise is clotting factors and the way blood works, they'll tell you that it doesn't really make a whole lot of sense to make that, to draw that conclusion. The idea is that the blood thickens with enough testosterone. And there's been claims that there's a 1-to-1 relationship. It's dose dependent, in other words. It is dose dependent, that's true, but it's not a linear curve. Because, for example, you will thicken the blood, which means simply that we're going to increase the number of red blood cells made. We're going to increase the hemoglobin and hematocrit. Well, certainly the hemoglobin and hematocrit, depending on other factors, it's percentage of your serum. As a result of the increased red blood cells, or in the use of testosterone. Sorry, but if we're just replacing what we had when we were, say, 20 years old, then there shouldn't be any sort of extra hemoglobin, red blood cell creation, and hematocrit. If that were the case, then every 20-year-old would have this thickened blood problem, right? As you go beyond into supraphysiologic, then yes, there becomes this dose-dependent relationship, but again, it's not linear. When you use a lot of extra, if you will, if you go very supraphysiologic and or you add anabolic steroids, you can get more hemoglobin, hematocrit, and red blood cells just from taking, that supraphysiologic dose. And also, when dihydrotestosterone levels go higher too, you can experience the same issue. And I should also add here that the reverse is true too. With deficiencies of testosterone, you can get anemic, which is just a way of summing up, your hemoglobin goes too low. I think in a male, depending on the lab, it's below 12.6. But it makes you feel weak and so on and so forth. We don't need to go into a definition of anemia. But what I see more often than not is because of what happens later in life to most of us, whether you have a 17-inch plus neck or not. As we age, the muscles of the neck, the tongue being a muscle, also can get larger and or more lax and collapse on the trachea or into the airway if it's the tongue, and create sleep apnea, difficulty breathing, such that with the leverage of even just physiologic dosages of testosterone, like you would see in a 20-year-old, and certainly with super physiologic dosages, you'll see an increase in hemoglobin, hematocrit, and red blood cell count, because essentially what you're doing at night is you're training in your sleep. So a 20-year-old's testosterone levels, presumably if they're nice and healthy, combined with bicycling uphill for 6 hours a day, would cause this similar increase. So I guess the take home is a lot of doctors will attribute the replacement therapy dose, or if it's higher than replacement therapy, supraphysiologic dose, will attribute the increase to that dose rather than the fact that it's combined with the fact that this patient has sleep apnea. And this is a whole other topic, because a lot of sleep apnea goes undiagnosed, because as your chances with age increase to have this typically obstructive sleep apnea, but rarely it's central, where your body just doesn't breathe. It doesn't send a signal to your brain doesn't send a signal to your lungs to breathe, if you will. The effect is the same, but because as we age, we're increasing the chances of having sleep apnea. We're increasing the chances also of having low testosterone. They kind of cancel each other out, and it goes very often undiagnosed, because doctor just looks and goes, well, your hemoglobin and hematocrit are fine. You probably don't have sleep apnea. At least I do, or I would if I didn't know what was going on, right?
There's a lot of people who
because it's an easy way to pick up on it. And if someone's not complaining, in other words, about the typical symptoms, like I'm tired when I wake up in the morning no matter what happens, and I wake up gasping for air and anxious at night, my wife says I snore like a bear, that kind of stuff, then you wouldn't look at it otherwise. But just looking at the labs, in other words, if you just saw the labs and didn't know anything else, well, the two can cancel each other out fairly easily.
Wow.
But the problem is doctors look at it and they find out someone's on a testosterone replacement therapy instead of doing the math, so to speak. And sorry about the long gyrations here of doing the math, but I want to explain. They'll go, oh, your H&H is high, your hemoglobin and hematocrit are high because of that testosterone. That is not the case. Now, in terms of clotting, again, going back to how this all started, the thickening of the blood, and that amounts to bro science. It's thicker, therefore it's more likely to clog. Let me see. I've come up with some pretty crummy examples thus far, but let me try another one. So if I were to fill this mug I have here on my desk, my W&O water polo mug, if I filled it full of sand is not necessarily sticky, but whatever stickiness factor sand has, if I filled it halfway or fully with sand, the sand is not any more sticky.
That's right.
Right? So whether I have a lot of hemoglobin, hematocrit, and red blood cells in my blood or not, it doesn't make it any more sticky. And a good hematologist will bear that out and say, no, that's not the issue.
That's a good example.
But again, you follow bro science type of, again, this is in the medical field now. Oh, well, your blood's thicker, so it has a better chance of clotting. No, it doesn't. And I'm not just spewing here, giving you lame examples of physiology with, analogies with sand and mugs and stuff. We've done studies to bear this out. I think the latest one was maybe 2015. There was one that I think, not to get anybody in trouble, but maybe Berkeley published it along with Harvard. But I remember reading in the Harvard newsletter about a study that was out of Frankfurt, Germany. And I don't remember how many were in the study, but it wasn't like another one that was even bigger, and I'll get to in a second. But there was an increased risk, albeit slight, of DVT or pulmonary embolism, which is really what can result from a DVT, a deep venous thrombosis, a blood clot being formed and either staying lodged somewhere in extremity or actually going to the lung, which can be a problem. It can be a big problem, meaning causing death. but there was a slight increase, I want to say, for a time period of maybe 6 months and maybe after a year, and I'm getting close, generalizing. After a year of replacement therapy, then it was all even again. So in other words, initially there might be a small increase, and afterwards you were like everybody else. Then there was a subsequent study of like 30,000 people or more over at one of the University of Texas schools. I want to say Galveston, but I don't know. Anyway, that proved that there was no correlation between the two. In other words, you get on T replacement and there was no increased chance of clotting. That's a pretty large study.
Yeah.
And the study design, by the way, in my opinion, was well done. So I think that one pretty much put to bed, for anyone who's doing the reading, the whole idea of increased risk of blood clots. But this is where it ties in with your buddy who apparently has the hotline to Big Dave's question board here. If you do have pre-existing factors, coagulation disorders, you can have like one factor, a pretty easy one. I think everyone, in other words, they have anatomic man or woman, which has the average, if you will. We use Leiden. There's two genes, obviously. If you have one gene, donated from mom and pop and others, but if you have one Leiden factor 5 positive and one not, you are considered normal. Okay, and that's considered a predisposition. I think it's 2 to 4 times more likely to clot than someone who has both positions on the gene negative for Leiden factor 5. I'm sorry I'm making this too complicated, but in other words, most people have at least one, and that's our norm. If you have 2, I think it's something like 40 to 80 times more likely to clot irregularly, I guess. So that we have to take into consideration. That's more real than I have thick blood, and certainly so you take those things into account. And you go, well, you just got through saying there's no additional risk using testosterone. Well, if you take, for example, the Frankfurt study, and then I would say, hey, to be cautious, if someone does have some of these pre-existing factors, like your buddy, apparently he's got 2 genes, 2 SNPs,
markers.
Markers for coagulopathies, they call it, a fancy word to say you have a blood coagulating problem. Then we'd be a little bit more cautious when first starting, again, based on the Frankfurt study. If there is indeed an increased risk, it would only be in the beginning from what we know now. And you might put that person in a different category for obvious reasons, because they're starting off with a predisposition. And so they may act differently than, quote unquote, the norm. So in general, not an issue. Now, this gentleman who had a subclavian artery clot extant, I don't know if he got rid of it or not, but if he's got damaged arteries, the damaged artery is not the issue so much. If you've got a pre-existing clot, then depending upon the cause, was it a coagulopathy, a predisposition to it, or was it because someone, was it traumatic, and otherwise it wouldn't have been a problem had someone not shoved a catheter up there and damaged the artery? I don't know.
Yeah.
But you can see how you might treat that differently also. If he doesn't have a predisposition, no blood disorders, then clotting too easily, then you treat him like anybody else. But his question, begs what we're talking about, which is, okay, how do you decide, and based upon what factors, in other words, do you consider HRT a risk for blood clots? And I just used the word HRT instead of TRT, testosterone. Really what we found is estrogen lends itself more to clotting when we're talking about anything but bioidenticals. I know this begs a whole other question, I apologize, but you can splice this up however you want. Hey, I'm on a roll. But with estrogen, when it was not bioidentical, meaning from a horse, for example, Premarin, pregnant mare urine, we found, I believe it was a 1 in 8,000 increased risk of clotting, because Premarin was roughly 50% estradiol and 50% equilin, which is a horse estrogen, and it's 1,000 times more potent on the human uterus. It was more potent on humans in general, so we saw an increased risk, this 1 in 8,000, I believe it was, of risk of clot formation in females who are using that. With bioidenticals, we didn't see that. We still haven't seen that. Add to that smoking and stuff like that, which, again, whether it's bioidentical or not, increases your risk. So arguably, hormones aren't a factor in a healthy human that doesn't have, pre-existing clotting issues. So I hope that wasn't too Byzantine an answer, but as with most things, common sense doesn't always prevail. As a matter of fact, it rarely does. Knowledge, based upon studies, usually does a way better trick than just the so-called bro science. Which again, I argue, a lot of doctors have been practicing based upon a notion that just isn't true. And again, the doctor to ask about this specifically, like in the case of your buddy or the gentleman with the subclavian artery issue, or vein, I forget which, probably vein, not artery, would be the hematologist, because that is their specialty. And I would hope that what I'm saying here would be echoed by someone whose specialty that is.
And that's why we do the show.
I hope
Thanks,
so.
Doctor.
Thanks.